Evening. Thank you for coming and welcome to STAR. My name is Ryan Schuler. I work for Employee Health and Wellbeing here at the university, which is part of the College of Health Sciences. Before we even begin, for those of you who have not been in this building before, I really encourage you to kind of explore and walk around. Down this main hallway is really where all of this translational research is happening. So if you go down the hallway on the right-hand side, you will see all of these different research labs. There's ones working on prosthetics, mobility for children. There's a virtual reality cave, biomechanics, nutrition. There are all of these wonderful things that are happening. And across the hall are all of the clinics that are open to the public. So again, if you have not been here before, I really, really encourage you to go down there. We have a speech language hearing clinic, a concussion clinic, which is new, the Delaware physical therapy clinic, and then also the nurse managed primary care clinic, which Carolyn will speak about a little bit today. Within that nurse managed primary care clinic, there's also a nutrition counseling service, exercise counseling service, and a health coaching service. So it's really sort of this one-stop shopping. So if you're going because you feel like your blood sugar is high, your nurse practitioner may be able to confirm that and send you right next door to the nutritionist to get a plan put together, work with a health coach to make sure you're adhering to that plan. So it really is sort of this one-stop shop where all of your care is right there. The topic tonight is the second in our series of 6. So this Conversations is really meant to be that. It's really meant to be interactive. So please, if you have questions, raise your hand. I'll come around with the microphone. Really, we want this to be as interactive as possible. So when we sort of came up with this panel idea, we really wanted to say what are the issues we're seeing with patients and their physicians, and how can we sort of bridge that gap. So a lot of times we're finding that patients have these questions, but they're too scared to ask, or they feel that they don't have time to ask. So we're able to bring all of these various healthcare practitioners from their different points of view here to you so you can learn a little bit more about their perspectives, but also have the opportunity to ask these questions that you may not be able to ask in your typical setting. So if each of you grabbed a brochure, you can kind of flip through this. It has the full bio of each. But just as sort of a brief introduction, our panelists, Carolyn Haynes, who is the director of our Nurse Managed Primary Care Clinic here at the university, Kelly Scott, who is with Penn Medicine Chester County Hospital, Tara Leonard, who is a health coach here with the University of Delaware, and then Guy Scottalotti, who works with our clinical exercise physiology program. And it will be moderated today by Rita Landgraf, who used to work for the state but has since brought her sort of passion for health and community health initiative to the university. I would also like to point out our VIP audience member. So the dean, Kathy Matt, is in the back, who is sort of the wizard behind the curtain and kind of gets this ship stays on course and kind of helps us all do what we want to do and make this innovative place stay. So we really thank her a lot for everything she does. And with that, I will turn it over to Rita. But again, if you have questions, please just raise your hand and I'll bring the microphone over so everyone can hear your question. Okay.
Thank you. Welcome, everyone. It's great to have you here this evening. We know it's a busy time of year for individuals, so we really do appreciate you joining us this evening. And I just want to share a little bit more about Dean Matt and how it, yes, I do, because you should actually stand up, Dean Matt. This is the only time I can actually boss her around, when I have a mic and I have witnesses here. But really, it is her vision. The reason why I want to highlight her work is because her work is indeed very patient-centered. And that is so critically important when we think about access to health care. And so what you see here at STAR is just one indication of the vision of our dean here at the College of Health Sciences, but it's even more than that because she also wants to ensure that we take this vision and we promote it through the community. That was part of the reason why she wanted to bring me to the university, having served as the cabinet secretary for Delaware's Department of Health and Social Services, and primarily reaching a population that has many challenges and therefore significantly poor health outcomes. Well, the dean and I, for the last 9 years, have been talking about how do we facilitate so all populations have good access to health care and therefore have healthier outcomes. So really, you know, through her vision and bringing these wonderful individuals here to STAR, and even our guest here, Kelly, it really does represent what we want to be able to do here at the University of Delaware. So I'm going to ask each of you, the audience has your bio, but I want you to talk from your perspective just about what patient-centered care means for you. So Carolyn, I'm going to start with you.
So patient-centered care, from my perspective, being a primary care clinician, is being the medical home for the patient. So that means taking care of them from whether it's a cold, whether it's a physical exam, to a mental health visit, to seeing them for a problem that they would need a referral to a specialist to, but the goal really is making it a medical home. So as Rita described our system here a little bit, we really do have a lot of that in-house, and patients really benefit from having one place where everyone knows them and where people are discussing their case with each other, so that there's no things slipping through the cracks. So to me, the idea of integrative healthcare to me is, that I'm the chef, and then there might be some sous chefs, but that this person knows that one person really gets the big picture for them, and that they're not farming them out to 15 specialists for things that we can take care of in-house, and really understand and know them well as they get older too.
So Kelly, how about from your perspective?
Well, again, I'm a nurse navigator, and I primarily work with breast oncology patients. So when I think of patient-centered care, it's more of looking at the whole patient and seeing what we can do for them. So I typically talk with my patients every day between them and their family, because some of them, may have questions and they'll call me too. And I help set up all of their appointments. And I'm kind of the point person for them, so if they have any questions, they typically call me first. They feel more comfortable calling me. So I think it's important to look at the patient as a whole person, not that they just have breast cancer, but it's the whole person and everything that they have going on. This is interacting with their work, that's interacting with their family as well. So you have to look at them as a whole, not just one.
Mm-hmm. So we've heard, from the chef, right? And then we heard from the navigator. And now Tara, from the lens of a health coach, what does that mean to be able to provide coaching from the lens also of a consumer or a patient? What role do you play relative to that? Because health coaching is fairly new on this scene, correct?
It is new, and honestly, when you ask the question of patient-centered care, that's the definition of a health coach, because that's what we do. It's about the patient. They lead the conversation. They help us to understand, honestly, the healthcare system in and of itself. What does it feel like to be in a healthcare system? What are the roadblocks? What are the challenges? And so the other piece of it is just honoring patients as being unique. They may come in with a diagnosis that's similar to other people. They may also have some sort of prescriptive care that they need to, or a care plan to get to a certain place. And, 3 people can come in and they may get to that place. It looks similar, but every single path is different. So it may be we listen to what they're saying, and nutrition is an area where they feel they need help. And so our job is to refer them. Often they get that plan, the nutrition plan, and they say, okay, now I have this information. And that's also a point in which the health coach comes in and says, okay, now let's look at that information. How do you implement it? The same thing goes for exercise or any other type of modality that someone may need to work with. So it's patient-centered from beginning to end with a health coach.
And Guy, so from your perspective, especially as you've heard the panelists before you, how do you relate to all of this? Because we actually have different team members, and if I'm the patient, I will be interplaying with all of them. Where do you fit into this team that's looking at how do I support you in a patient-centered way?
Well, I've been in healthcare my whole career, and the earlier part of my career, rehabilitation, primarily cardiac rehabilitation. So the consumer who would come to us, very fearful, obviously they had an event, a diagnosis, and at the time we're using one intervention, exercise. Well, very early on you realize that basically many chronic illnesses are multifactorial. They can be choir men and women about the exercise, but if they're not eating right or they're not doing things to reduce and manage stress, then you're really going to have limited benefit. So early in my career, directing outpatient cardiac rehabilitation and diagnostics, I've pretty much learned that if we wanted to get more of a complete holistic approach, I'd have to farm out their care. I'd have to send them to a clinical dietitian or a health psychologist. And I always thought, boy, you know what? It'd be great if we had the whole model, not only providing all these different pieces, but being able to communicate with, again, the patient at the center of that.
So what do you think, since you're all like focused, and that's what makes you so wonderful, is because you already understand the value of that protocol from a patient perspective. What do you think, because again, this intersection, this comprehensive, collaborative way to deliver healthcare is new, even though probably each of you have always valued that, you know, and usually people who get into healthcare value that. So from each of your perspectives, what are the barriers and why isn't it universally adopted? Does anybody want to jump in first?
How much time do you have?
Yeah. It's a deep question.
Well, on a level, I came from a large hospital system, and a lot of people think that, oh, if you're with a hospital system, there's a real continuum of services, and everyone knows what everyone else is doing, which, as you probably realize, is not the case. There is, unfortunately, and I think because of purposes of efficiency, there's a lot of silo thinking. And the problem is that if there's a breakdown in communication, the worst thing that happens is the patient gets left out of the mix. So working on that is very, very important. From the perspective of the patient, things that the patient can do to certainly get the most out of their medical appointments would be, for instance, something simple like preparing their questions before they see their medical provider and not doing it alone. Having a caregiver with them oftentimes can pick up and take notes what the patient may miss, so the patient really gets the most out of that interaction with his or her care provider.
Does anybody else want to chime in, again, through the lens of the patient? I think each of you were selected to join our panel because you already bring that from a value perspective as well as from a delivery perspective. But let's imagine if you, and all of us are consumers of healthcare, right?
Right. Yeah.
The four of you are consumers. So how do you handle when you are navigating or interacting with systems of care and they're not patient-centered? I heard you say, Guy, write your questions down ahead of time so then you have something, you have a tool, you know, in case you're in that situation. It can cause some anxiety if that treatment provider is not responding to you. I also heard you say bring someone with you because sometimes, you know, some of us have white coat syndrome. And even though, you know, when we're using our executive functioning every day for work or for school, we're very good at it. But when we go into the doctor's office, we kind of lose all that. So many times it's good to bring someone with you that could be that advocate. But what other strategies can we put into play if the response we're getting on the other side is not really from a patient-centered value? Well, Kelly.
I think for myself, if I have a patient that's trying to say contact a doctor's office and they're not getting through, or the doctor's office is saying, well, we can't see you for another 2 months. Now remember, I'm working with a lot of oncology patients. So you can't really tell an oncology patient, we'll see you in 2 months, because they're not going to handle that very well, nor is their family. So a lot of the system that I work in is really good because we can have that interaction through computer. I can go to the office. We do a lot of texting. I mean, I have a work cell phone, so I'm texting physicians, I'm texting nurse practitioners.
And they're responding to you?
And they do respond. Now, sometimes I'll try and ask the patient, do you want me to do it, or do you want to call on your own, and see where their comfort level is. But sometimes they may say, I want you to do it. Now, if I have to go to an outside facility, which sometimes I do, because a patient might want a second opinion, or they initially had their work there and then I need to try and get it, I write names down, date and time, who I spoke to and when, and I'll give it like a day or two. And if I don't get any feedback, I'm calling again. If I have to go to another level, like I will say things like, I want to speak to the manager, or can I speak with the doctor directly? Usually you'll get a little bit then. It's not that you're being pushy, but I would do that for myself. If I had to call my doctor's office and I wasn't getting anything, I would ask to speak to the next person in line. So I do think what you said too about consumers is that we can shop around.
Absolutely.
So if even myself, if I'm not happy with my provider, there are hundreds others out there. So if you're not getting what you want from your provider, you can certainly leave. And we know that off of surveys that everybody has to fill out. I have to fill out. And I think the hospital has gotten good, healthcare providers in general, at reading those surveys and listening.
So more feedback from the consumers, even at that system level, can inform the system as well. So not only for you as an individual, but if you provide that level of feedback, it can improve the entire healthcare system. Now, is everybody afforded a navigator, or is it generally when people are facing the need for specialty care?
I think it depends on what healthcare institution that you're in. The one that I work for, if you have a cancer diagnosis, nurse navigator will work with you. They'll work with you at the beginning all the way through the continuum of care. And then we actually have one that's like for survival too. So after you've gotten through everything, then that nurse navigator works for you, so you don't feel that all of a sudden you're done, but you're a little scared still and you're lost. Now, in regards to practices, I think there's like the health coaches. I do think a lot of institutions are getting better at getting nurse navigators. There's also a term called lay navigators, where you're not actually a nurse, but they get a certification and they can do almost the same thing without that huge, nursing background. I think that hospitals are knowing the importance of navigators. I've taken care of many women that they're like, hey, you know what, my neighbor was diagnosed with a pancreatic or a lung and went to such and such, and they didn't have a navigator, and they had a really hard time, couldn't make appointments, didn't know what to do. And I'm really glad that you're there, because we take that burden off of them. It's one less layer that they have to worry about.
And you work with the loved ones as well as the patient.
We work with the whole entire family. So we try and be very open to them. So like I said, normally when I meet with the women, I'm like, this is my contact information. It's the day and age of texting, so I'm like, if you don't want to call me, you can certainly text me, you can email me. And then their son, their daughter, their spouse, their loved one is like, this is so-and-so's husband, and I had a question about this appointment. So we try and be, very open to everybody.
That's great. Carolyn, so as people come through your clinic, how do you reinforce that patient-centered perspective for both your team and then for the students who are working towards being our workforce of the future?
So we, the Nurse Managed Primary Care Center is in the process of becoming a patient-centered medical home. And as part of that process, every patient that comes through as a new patient gets an introduction letter to what being a medical home means. It tells them what our responsibility is to them and what their responsibility is to us being partners in their healthcare. So they are given the introduction, they are introduced to, we have a care coordinator who is a nurse, and we hired her in April. And it's been amazing having her because she's kind of our navigator. If I need a patient to get in for something quickly, you know, you could literally sit on the phone all day, and I'm sure you've had to do that. She gets the job done. She'll go the extra layer and say, they didn't call me back, I'm going to their manager. It's being an advocate for the patients, and we are consummate advocates. So we get it done, and you know, the next time they may take our call quicker. But it's a bit, you know, closing the gaps in care is the most important thing. So when patients come into us, they're advised that we're advancing towards a medical home, and all the things that go along with that. And then when the clinician sees them, we take that a step further and introduce all the services that we have in-house, which it just closes those circles. People aren't dropping through the cracks as much.
Right.
So how do you support a patient? Because sometimes we look to one person, right? Because that's how our healthcare system has been set up, right? That we look to that one person, but now we're going to team-based care.
Right.
So how do we help that patient understand that you're a unified team? And, you know, maybe it's not always Carolyn that is going to guide through the process, but Carolyn's still a part of that team. So how do we help a patient adapt
when
to
patients
that?
come in, we encourage them to pick a primary care provider, and there are 5 of us. Once they pick that primary care provider, we pretty much assure them they will be able to get in with me or with one of the other clinicians definitely for routine visits. If it's an urgent care visit, they may see one of the other clinicians, but they're always advised that we discuss, we share information, we're on the same electronic medical record system. If we are walking them down the hall to meet Tara for health coaching, a lot of times if she's available, we're taking them and introducing them and giving what we call a warm handoff. Basically, the person's going to realize we work with this person, we collaborate, they're all excited to share their lab work when we have good outcomes of the health coaching. So they're like all excited that we're all on the same team and that, oh, did you talk to Tara yet? Oh, because I saw her last week, and they feel that connection.
So it's all about relationships primarily.
Yeah.
So Tara, you want to pick up on that and what your experience has been as we progress to team-based care?
So far, I mean, we've been doing this for a little over a year, and what we're finding is that the more we get to know each other, and that's something we were kind of discussing today, and making sure that our communication is face-to-face as well, even within our clinic, that warm handoff is always there. And we're able to sit with a person and talk by first name about the clinicians that they're working with. You know, have you seen Sharon? And they want to share what they learned with Sharon. And it makes a difference for someone when they know they don't just know that person, but so do you. I mean, we look at HIPAA and whatnot, we have to do it the right way, but still, it's a very different situation.
But you're showing how to do it in the right way,
Yes.
Even with the privacy
Right.
pieces to it. So privacy isn't necessarily a barrier.
Not in our situation.
Not in our situation, yeah.
Because we don't make it a barrier.
Right.
We do what we need to do to make sure that person can get through and they can communicate, and we make them a priority because they are a priority. It's our job.
Yep.
Guy, I saw you were ready to jump in,
a few
please.
things I was going to, well said. But coordinated care is just that. The team being aware, and with things like electronic medical records, brings that information to the forefront. Scanning it beforehand so the patient knows when you're seeing that patient that you're aware of what's going on. The challenges, their updated medical history, those things are important. And presenting that coordinated approach helps you understand basically the challenges that they have, as well as learning their goals, and help set short-term goals as well as long-term goals with the patient is really important. Things that are achievable, that provides feedback, very, very important.
So Kelly brought up an interesting solution relative to, as consumers, we think of ourselves as patients when we talk about interfacing with the healthcare system, but we're also a consumer of healthcare, right? And when you think of yourself as a consumer, that also means then you think of the choices that you have, because as consumers, it's an open market. It is an open market in healthcare delivery, but many times patients are reluctant to actually do that.
Yeah.
How do we support patients in understanding that they're also consumers, and if they're not getting, you know, the product that they are entitled to, or one that makes them feel valued, right? How do they then go to the next step? Because I know of many people who will keep going to that provider and they're not happy with that healthcare provider at all, but there's either a fear to exit because that person has been providing their health care.
Right.
There's also, I believe, sometimes a fear that they will have a reputation that gets spread around the entire healthcare system, right? Or they fear, like I'll just deal with it. I'll just deal with it. And I want to add something else. When we do that as patients, we actually are harming our health more than helping our health, because there's elements of anxiety, then probably blood pressure, stress that we add to that interaction with our provider. So would each of you kind of give us your perspective on how to navigate that to get to the provider that might serve them the best for what they feel comfortable with as a patient?
In my experience, so I've been a nurse practitioner for 10 years and in healthcare for 30 years. I feel somewhat it's a generational thing.
Yes.
Because, you know, back, you know, when some of the folks in their 70s and 80s now, well, but they're my doctor.
Right.
But they're my doctor. And that can be regardless of never getting a call back or not getting in for 2 weeks for an urgent visit, because they just feel beholden to them. I tell a family member, if you don't like the Acme, you go to Pathmark, and I stand by that. If you know, it is a consumer-driven. We are in a consumer-driven age of healthcare, and there are a lot of options. So when I see a patient, we do see a lot of new patients in our clinic. And I can tell the minute I'm being sort of interviewed, where I have a primary provider, but I heard about you guys because I came to a health fair. So then they run through some questions. How long of a visit will you give me? And what would you do with this medication choice? And I don't mind that, because again, they're consumers. So, you know, interview as many providers as you need. Pregnant women interview pediatricians. Why shouldn't everyone interview their healthcare provider? So I encourage those types of visits, and if they come back and see us, then that's great, and a lot do.
I love that you just talked about the pregnant women, because sometimes it's easier for us to advocate for our children than it is to advocate for ourselves.
Absolutely.
And if you think about it, we need to advocate for ourselves in order to advocate for our children. That was very poignant. Kelly, do you want to address like how do we accept that it's okay to interview others?
Well, in my area, again, I'm working with oncology patients, so they need to feel comfortable. So normally I'll start off and say, you're in with this such and such a surgeon. Let's start off there. And they'll automatically sometimes, because, you know, they're reading stuff at home on the internet as well.
Yeah.
I'll say, come prepared with questions just like you do, and meet with the surgeon first. Depend on how you feel from that meeting. So if you have a good feeling from that and you feel confident, then you kind of know that you want to stick with that person.
Yeah.
But then sometimes it might be the second or the third visit, and they'll actually call me and they're saying, I don't really like the way she treated me, or I had to wait a really long time and she wasn't really apologetic about it. So I'm like, okay, it's not a problem, because don't forget that providers know that you can do that. And oftentimes they'll say, if you want a second opinion, if you want to go to another doctor, it's entirely up to you. And I've had family members.
Are they offended though when patients do that? Because sometimes people think they're offended by that.
No.
If you want, what I tell patients is, anyone who's arrogant enough to not want you to get a second opinion is not really worth your time.
I mean, the providers that I work with will actually say, you are welcome to get a second opinion, and it is fine. And they would rather you do that. And oftentimes you'll go get a second opinion and you're like, oh, well, it was the same as the first, so I'll say. It's within your right. I would do it. We would all do it up here. If you ever have a question, or if you feel like, I waited an hour to see you and you didn't even apologize for that, then it might be time for you to look maybe for someone else in that practice. You might not need to leave that practice, but maybe you want to see another provider. They do not get mad. They're not going to put a mark on your chart and say this is the person to stay away from.
Your
I
flag.
don't even think we can do that anymore because everything's like monitored electronically.
Right.
But it's within your
Although
right.
she did say anymore, so
But I mean, I always say, if you feel uncomfortable at all, let's go to another provider because it's your body.
That's right.
So.
yeah, it's one of the most intimate things, right?
Yes.
It's your body.
Absolutely,
right?
and you have to feel comfortable with what they're saying, how
And who's
you
supporting
feel.
you.
Exactly.
Right.
Exactly.
Tara.
Yeah, so, with the position that I'm in, it always starts with a conversation, and often we don't know exactly in the beginning how it all will start. And so someone may not really talk about the fact that they're not happy with their PCP, or they're not happy with, whatever physician or health professional they're working with. And you have to almost talk them off the cliff a minute and just say, well, tell me, how is it going for you? How is the relationship? And you've been on this, I'm worried about this medication, the side effects I don't really like, and you have to talk through that. It may even be that goal setting for them is looking out at references and seeing, where do I want to go?
Yep.
I also have found that with some of the population, they are kind of grandfathered into a new physician, and they're still afraid to leave that practice and saying, I have someone new that is now taking my file over. They don't know me. They don't know anything about me. And so that's another conversation. But once again, it starts with, how do you feel?
And Tara, isn't that the benefit of team-based care too?
Yes.
Then you're not relying always on one person. So, because we know people also, professionals in the industry many times will come and go. But if you have team-based care, it's unusual that your whole team turns over. So isn't there a value in of itself to engage a team-based framework?
Absolutely.
Absolutely, because then you have one more person to talk to.
Right.
And I think we often think that we have a rapport with someone, may really be misguided and know that and we may not. And it may be that we do have to talk to them a little bit more about how they feel about, because it does go back to feeling. And then the other piece of that is even health literacy, is that oftentimes we're missing the mark on really understanding, does this person understand even their own plan? And if they don't, then they're probably afraid to leave to think that this person knows more than I do. They don't trust themselves as being an advocate for their own care.
So Guy, how does that resonate with you?
Well, very importantly, I think you can be the most educated, the most intelligent provider in the world, but if the patient doesn't feel that you're connecting with them or that you care, you've lost them. Yeah. And it's basically, so when we talk about the positions that we're on, it's sometimes it may be the RD or the registered dietitian, it may be the physiologist, health coach. It may be the person who answers the phone when you call for an appointment.
Yep.
Your attitude, the energy in your voice, the connection oftentimes is made there. And if you can develop that thread, because I don't know all your backgrounds, but if I can find that thread that connects us as human beings, that's golden, because that's when people know that you care, they're going to be open, and they're going to want you to help them get well. It happens again and again. It's not related to any particular profession, but it's having that right attitude and dealing with patients, because it's the hardest thing that you're going to do, but the most rewarding.
So if you could design how we interact with the patient population in our delivery of care, what would it look like? And do you think we're on the right road to getting there, or are we missing some components? I know that was a lot in one.
Communicating, you mean at a visit or?
Just overall, we're focused on really moving to a patient-centered medical home model.
Right.
We're focused on team-based care for the reasons that we talked about. We each bring a different perspective right? In working with that patient, we're in our own more or less disciplines, but we do better when we combine them, especially for that patient in that team-based framework. So I think we're on the right path, but let's say you were creating a system. What pieces are certain or that might be amiss, and how do we kind of advocate for that, especially from that patient perspective? And you probably see it when you interact yourself as consumers in healthcare.
Absolutely. And I think we probably all, I mean, I would love to fix a lot of the issues that we have. I'm like, this is a great question. I think so if you're looking at the model that I'm thinking of, I think communication is key. Everybody, from the office staff, office nurses, medical oncology, radiation oncology, diagnostics, like the ultrasound, mammogram techs, everybody, completely. Because I think we're getting better. I think we've listened. We know what we want, so we want to give that to our patients. And so we're getting better, but we still have a little bit of ways to go. So I would say we still have to communicate more. I think that some people still carry, this is my job, that's your job, and it shouldn't be like that. So it shouldn't be like, let me pass the baton to you because this is what you do.
Okay, can I stop you there?
Absolutely.
Because I think that's really an important item.
Yeah.
Because I think even if the team themselves sometimes thinks from that siloed perspective, then patients also may think of it from that siloed perspective. This is my oncologist. This is my primary care, professional. This is my health coach. So let's shift to how do we go from that to integrative care. And can you talk about what integrative care really is?
So for me, integrative is looking at the person as a whole. It's mental, physical, psychological, it's everything, nutritional, everything as a whole. So if you are looking at the patient as a whole, you need to be in tune with that whole care team. Primary care, if they have anything going on, respiratory, cardiac, oncology, rehab, wellness, you need to look at that person as a whole. And like I said, I think we're getting better, but there's still some barriers, and I think it starts at the top. And you need to work with everybody, even the receptionists. Let them be warm and inviting when they walk through the door, when they answer the phone. Because I've had patients call me and say, I love that doctor, but I can't stand that office staff. And and I might go up there and I'm like, I can kind of see why.
What do you mean? Yeah.
So, and it's unfortunate. So, like, what is it? One bad apple can spoil the whole thing.
Yep.
For sure.
That's right.
That is true.
Anybody else want to reflect on the integrative care and how sometimes even patients actually silo the various disciplines because we haven't been treated in a team-based care framework for, even though it may have been going on behind the scenes, right? I mean, it's not that team-based care has never been here, but it hasn't been.
It has its issues.
Exactly.
So to me, integrative, I agree, is looking at the patient as a whole. But similar to that patient-centered medical home concept, it's not sending them to all these different specialists if they don't really need it. Right. So then maybe they have one or two, but then you're taking care of the rest. Because those other two, in a perfect world, they're sending you a consult note. So you can say, oh, I see you saw the cardiologist and he decreased your metoprolol. That's great. The reality is sometimes they don't send a note. And then the reconciliation's messed up and the patient's on 2 of the same medicine at different doses. So there's a lot of gaps that are there. So there's room for improvement, but it's better than it had been.
And that's why communication is so vital too, right, Carolyn?
Yeah.
Because if you're not getting that information, then as patients, we want to ensure, that information carries with us to our providers of care. If you have that team-based framework, and if it's really solidified, it will happen organically because the team is serving the patient. but we're not exactly there yet. So
It's a lot
patients
better.
need
It's a
to
lot better
check
than it
in,
was.
but always check in, because sometimes they might not have that most important information
Yeah.
that you may be carrying with you, and you can't
Right.
make assumptions that they do. And that brings me to, because you know that we always ask the patient, what are we doing for you today, right? Especially prior to operations, and that's to safeguard. But it can also send the message that's almost reverse. Why don't they know what they're doing for me today, right? So how do we address that? If we're truly going patient-centered, but yet we have these safeguards in place, sometimes to the patient, right, it may appear as though I'm just a widget and I'm on the assembly line and they're checking with me to make sure, you know, they're getting the right part of my thyroid that they're going to do surgery on, right? So where is that balance? And I think it gets back somewhat to health literacy as well, because we're required to do that. But to a patient who may not know that, it may appear that team member doesn't even know what they're doing to support me today.
Well, I think we need to be honest as providers. So if I'm talking to a patient that's not normally mine, and I had this example for today, I was covering for somebody else. So I had to call them and update them with their appointment. And I said, I'm so-and-so, I'm covering for her. And she was like, okay. And I said, I'm calling you with this appointment. I think we need to be honest. Don't try and finagle it through and let them think that we know because you guys are going to pick it up. I would pick it up. So I think we need to be honest and say, okay, I read in your chart this. Were you aware of this is what needed to be done? And kind of let them know along that lines. Honesty is huge.
Definitely.
If you lose that, then it's really hard to gain that back.
So honesty and transparency,
Right.
Yeah.
right,
Yeah.
Guy?
Even in a large hospital system, if a patient calls and you're busy, again, trying to field the question, and if you don't have an answer, say that you're going to call back at the end of the day. It sounds simple as anything, but calling the
Call back.
person back shows respect.
Yes.
Yeah.
And you know, you may not have the answer, but boy, oh boy, how would you feel knowing that you're on their mind and it's important that I call you? You may not have any information,
Yeah.
but tell them that the process and let them know
It's really
honestly that the
important.
process is moving
Yeah.
along. Goes so far.
It does. And they
does.
really do appreciate if you call them back at 5 o'clock and it's like,
Yeah.
oh, I didn't think anybody was going to be there.
Right, right.
And that 5 o'clock phone call on a Friday can go a long way.
But Carolyn, you mentioned a generational thing. Mom, I'm sorry about this. My mother, very strong woman, she would be having some health issues, but if it happened at 9 o'clock a.m. on a Saturday morning, can't call the doctor because they're on the weekend. If she would wait unless we did something to her
Was she
until Monday
nervous,
morning.
though, that she might get somebody else on call?
No, actually,
No?
no. She just said, you know, they have to have a life there.
Yeah.
But
Oh, they
if
have to have a life.
if she had a problem, she would expect that they would find the answer to it right away. You know, so it's one of those
Yeah.
things. And
Balance.
you know, again, it's funny that you know we would think nothing of shopping around for a new refrigerator, but with a
I know.
With our own precious,
Yeah.
right,
I know.
right,
Yeah.
with our own precious health,
Yeah.
we are more reluctant to do that.
Right.
Now, Tara, tell me, what is a health coach?
Oh, question. Health coaches work with people in all different areas of whatever it is, but in terms of health behavior change. So maybe it's a recent diagnosis, or maybe it's just something as simple as, you know, I really would like to start exercising. I have a tough time putting it together and sticking with it. We offer accountability, checking in with the person. We offer the opportunity of resources. We're accessible because we can work face-to-face, we can work telephonic, we can Skype. There's lots of different ways that you can access a health coach. And I would say the more that I'm involved in this, I will say that accountability is probably the key factor, but that the accessibility, the accountability, and being able to help a person navigate a system is an important thing. But health behavior change is where it's at, and that's what we do. You know, you had asked a question about what would be the perfect situation, and I really wanted to answer that.
Oh, good.
So I will.
Glad you brought us
I'll take
back,
a second.
Tara. That's great.
So pardon me, but So there's a model there that's being used in several different places, most likely in the primary care setting. But basically, a health coach meets with a patient. We would call them a client, but a patient first, and it could be a 10-minute conversation. There's where your reconciliation of medications can have the conversation to find out where are you, what are you taking. You can say, what questions do you have today? Get the person focused for that conversation with a healthcare provider, because a healthcare provider does not have a lot of time, and we have to honor that and understand that. It's just the system we're in. And then they can get themselves focused for the conversation with the care provider. The care provider meets with the client or patient, and then afterwards we can come back again and say, so what do you understand about your care plan? Do you understand your care plan? Once again, assessing that health literacy. So in my perfect world, we as health coaches would work within that system and be meeting pre and post with clients or patients. So I wanted to just throw that out there. And I think that's hopefully a way that we can move forward.
And Guy, what about prevention and wellness? We as a healthcare system have really been a sick care system, right? That's really when we come in for care. That's just been the way the system has been created. When it really got addressed in a profound way was through the Affordable Care Act, when it really started looking at transforming our sick care system more to a healthcare system. And we're all across our country still attempting to do that through how do we pay for care. But as patients, what does that mean to us as a patient if we have been accustomed that we interface with the healthcare system usually when we're sick, or we need an operation, or we've had an injury?
That's true. That's a hard thing. A lot of times a person may get an annual physical, their blood pressure is going up, they may have an exercise test, and they pass the test. Forget that their lipids, their cholesterol is going up and all this. Well, I passed this year, I have time to work on it. And the reality is that we don't really do anything until something happens. And I will tell you, my experiences in working in rehabilitation, the initial part of my career, cardiac, it may not be the first event that turns the person around. They may get on the medications, they're feeling better, they have that false sense of security. If fear was the only motivator to keep them doing what they need to do, what happens as time goes on? Fear wanes. And if fear is the only motivator, then we slide back into those habits. Then, if another event happens and they happen to survive the event, well then you can make some changes. Prevention, I think it has to be individualized, personalized. Prevention should be accountable. You need to set short-term goals with the person, not what your goals are, not imparting what your goals. What is realistic for you to be able to see in a short period of time? What's the measuring stick? I always talk about outcomes, but really, you have to measure outcomes, and preventive and wellness care can show those outcomes. Not only is it very reinforcing to the patient, but boy, if you're trying to influence a payer down the road, when you can show hard outcomes that because of these interventions, we're reducing medications, we're reducing ED visits, we're delaying or preventing surgery, that's where the rubber hits the road. And that's what I envision to be the model that we...
And that's also the value to apply the research to the actual practice so that we can replicate that within the system. Now, I'm going to turn it over and open it up to the audience. Ryan, did you have anything you wanted to say before we go live?
I had my own question.
Okay, that's what I thought. Yeah. You can start it out.
Oh.
It's recording.
Okay, so my question was, a lot of what you're talking about is from the provider perspective or the system perspective, which I think is really interesting to hear just because we don't always think in that way. But as a patient, how accountable am I for making those changes, and what are sort of tools you can give me? So if I know that my healthcare provider isn't perfect and I know that my system isn't perfect, what can I do as an individual to make sure when I go in, I am ready, I know what to expect, or I can sort of have the best experience for myself?
Or you shop around if it still doesn't work.
You're asking what you can do as a patient to prepare?
Yes.
Well, certainly understand and learn about what you can do to help and manage your own health care. And people call them 4 pillars. basically healthy diet, essentially, regular appropriate exercise, developing and acquiring a good support system, and finding ways to reduce stress would be 4 key areas that we all can do, regardless of what our health status is.
I also think it's important to follow the guidelines, females versus males, in regards to testing as we get older, what's needed. Of course, the healthy diet we all know about, limit our alcohol use, exercise, get up and exercise. All those things we can be proactive as patients. Even I'm a patient. But you also have to follow the guidelines. I mean, I've unfortunately have taken care of women that it's fear, and it's also just us being busy. I mean, you're a mother, or you're taking care of your parents that just moved in with you. You forgot to get your mammogram, and 2 years later, you're like, oh, I have to get my mammogram, and you go in, and a woman has a huge cancer, and they got busy. So it is important to keep, to take care of ourselves so we can take care of our family members.
Right.
Well, and sometimes that's the value also of you as a navigator, but also the health coaching. Because if we're looking at changing behavior or striving for healthier outcomes, sometimes we need that extra support in how to achieve that. We even talk about this time of the year, right, that we make our New Year's resolutions. Many times that has something to do with health. We're going to either lose weight, we're going to exercise, we're going to get more sleep. And how many New Year's resolutions make it for even that first month, right? So what strategies can we put into play that will actually, because the desire's there when you make it. Nobody makes it because they don't have that desire. But then how as patients can we achieve it based on, especially the model of a health coach?
Right. So Guide says something about social support, which is a huge piece. When we have time to talk to someone in a health coaching conversation, often we can assess that. We can say, what is your support system? A lot of people just need to know that there's someone who's going to be checking in, to know, or to help them write a goal that's achievable. Oftentimes we have grandiose ideas about where we want to be, and someone to talk us through and say, okay, so how doable is that in the moment? And maybe we can come up with something a little bit shorter term and then work week by week. But assessing the social support, and I would say that most of my clients that are most successful in whatever change it is, they've somehow reached out and opened the conversation to someone else. And then they brought that person into that change. And I think that that's a huge piece. And it sometimes isn't within the family. Sometimes it's without the family. It's looking at a support group or getting involved in a knitting club. Believe it or not, things that are stress reducing. And knowing that someone's going to say, hey, that person's not here. I need to know where they are. And it's more than one person. And the more layers of accountability we add into change, the greater the change sustainability may be.
It's definitely the accountability piece. If they think someone's going to, kind of nag at them, come on, I thought you weren't going to pick up a cigarette. Oh, I thought you were going to go get your mammogram. It's why, Alcoholics Anonymous and all these types of organizations work. There's places where people can go and they know someone's going to keep them accountable. So our health care coordinator sends out mammogram orders to patients who haven't been in and calls to follow up. And sometimes you just need that extra reminder to kind of do what you need to do.
Okay, we're going to open it up. Please raise your hand, and Ryan and Tom's going to start us off.
I have 2 questions, so I apologize. I want to expand on the original question. What ways are you giving the patient to help make the system better? So in other words, we addressed what the patient can do in their accountability, but what ways can I say, you need to improve this. You need to really sort of look at this perspective from this lens.
And
That's
Kelly,
my
I
first
think
question.
you talked a little bit about that relative to the evaluations from patients.
Well, we have, so if a patient comes to our healthcare facility, anything that they get done, they're going to get a survey.
Right.
And a lot of times I know we all throw the surveys in the trash or we discard it in our email, but that's really important because we know where we messed up or what we did really good at or what we need to do better at. So I would say surveys, and also, believe it or not, letters. You can send a letter to a CEO of the hospital and they're going to read it. because letters have gotten filtered down to us. A letter of your experience, what you liked, what you didn't like, writing people's names and saying what service they provided, that really shows us what we can do to get better. If someone's just mad about something but doesn't share it, then we don't know how to improve it. Or if you're happy about it, share that experience, because we need to know that too. So I just can't say enough. Letters and surveys, I mean, from you guys, it just really goes a long way.
And aren't some providers of care are actually setting up patient advisory councils
Yes.
to actually support from
Have a
that
community
lens?
member involved, yeah.
There are like
What
patient...
about the, I'm sorry, but I want to expand that. What about blogs and Facebook
Social
and social
media.
media capabilities
Yeah.
and, you know, the other ways that, you know, you can get groups to start talking about how things are done better and the system is improved?
Well, there is the social media aspect. Like the hospitals are on like Facebook, Instagram now. I know people from the hospital, like in PR, they monitor those sites because you can get people to put anything that they want on there.
But let me expand it. I'm just probably not asking you right, but how do you inform me on a regular basis, probably from a marketing campaign or a regular external contact campaign that starts proactively informing, educating, and allowing people to build that community of networking that, you know, can help change the system?
Well, I think that it's important with your local hospital or even like family care practice, they send out mailers. I get tons of things in the mail about local events, blood pressure screenings, mammogram screenings.
God, see, nobody sends me anything.
Oh, you're going the wrong place. But I mean, we even have, believe it or not, people, if an email comes out to you from a hospital, all right, people can monitor at the hospital who opened it. Not who, but how many people opened it. So they can say, well, we sent out 500 emails and only 100 people opened it. But if you open that email just once, you can send, oh, wow, like they're having nutrition screening, or it's getting ready to be the winter months and there's a falls and prevention screening. So things are being sent out, but it's us, and it's me too, because my practice, she sends out stuff and I'm like, delete, I don't have time to read it. But to advocate for myself, and I have to be accountable. I mean, we can send out mammogram screenings and you didn't have this, but you also need to be accountable and say, you know what, I may not have time, but I'm going to make time and I'm going to go.
My second question, I apologize, I came in late, so maybe you already covered this, but could you tell me how you're thinking about patient family-centric care?
So,
because a lot of the interaction is a stress on the rest of the family.
That's right.
So most primary cares, well, a lot are moving towards a patient-centered medical home. So in addition to the patient being at the center of the care with the whole care team, we encourage them to, on their HIPAA form, include a family member or two, so that if your wife comes in and then she becomes ill and you want to call us to tell us about it or tell us or ask us questions, we actually can share that information. And some patients are still hesitant to do that, but we encourage patients to be open with family. And if they have no family members that they are at that level with, a good friend, someone that we can share information, and they can bring them to their visits too. But as part of a medical home model, the patient is kind of at the center of that. And we did talk about that at the beginning, but we all, and part of that is the patient knowing that they are an advocate for themselves and that they are also accountable, like they're responsible. I tell patients, no news is no news. So if you get your lab work done and I don't call you within a week, you need to call me and tell me you had it done and where, because I didn't get the result, because you will always hear from me. So if someone comes back in 6 months later, and this has happened, where they say, well, I just assumed that ultrasound was normal because you didn't tell me. Well, no, things happen. Not all places are, things happen. Where I didn't get it, and I had one situation where there was not a normal finding, and months had gone by. And I document patient, agreed to call. So I always tell people, no news is no news. So they have to be a participant with us. We're partners in their care.
And sometimes we have to help them, though.
Right.
To be
Yep,
that.
yep.
Because, if you think
Educate,
of traditional healthcare, it seems to be something that's done to us.
Yeah.
As opposed to something that's done with us. So we have to also.
We reiterate it every
Yeah.
visit. Yeah.
If I can add to Carolyn's point here, and unless the floor plans have changed with the new building, when we talk about patient-centered care, it's not just words. When the patient comes into the area, the design is that patient pretty much stays at the center, and all the disciplines actually come and see the patient. So that patient's not walking all through the center, you go here and here. The sense is that I'm at this spot, I'm at the hub,
right.
and they're all coming to see me, which is...
Which then will also help with that interaction, because they'll feel that they are empowered if they're at the center. And I think you had something. Did you want to say something or ask a question?
I have a question.
Yes.
So, and this could be also in two ways. I know you talked about some good initiatives, and they're very valuable. But how do you communicate as an educator or outside consultant advocate to administration some of these great ideas? Two is that, let's say, still I believe that some doctors don't believe patients are customers. How you communicate to them that, they are customers. So if you can highlight on those two areas. One is how you can communicate the value of what you're doing, you're saying, to administration as well as to individual levels.
Guy?
Well, I don't want to monopolize, but I will tell you, whatever program you're doing, certainly you have your heart and soul in it. You want to be able to show good outcomes. And these outcomes need to be reported to the administrators because they're the ones who make the decisions. Certainly the most important people, your consumer base, are the patients that you're seeing. I always said, treat the patient the way the patient needs to be treated. You're getting good outcomes, everything falls in place. If you're doing a good rehab program or whatever, you make the patient healthier, help the patient, the doctor's going to be happy. They're going to hear it, they're going to see it when the patient sees it, that sells the program. If you've got something really good, you're getting great outcomes that are measurable, and here it goes, that outcomes thing again.
No, that's right.
Then you need to broadcast that to the administrators. Believe me, administrators want to have programs that are thriving, that are successful. They go to the payers. And when you're a payer and you're looking, okay, do I want to pay for this model of healthcare where it's tertiary, it's end stage, high cost, few good outcomes, or have something here that's hitting a lot of the buttons. It's less costly, but ultimately it's keeping people healthier. There's a lot of markers that you can see. Fewer emergency room visits, so many markers that show success. Those programs need to be broadcasted because administrators are consumers, patients are consumers, doctors are consumers. It all goes full
Research,
circle.
too. I mean, we need to keep capturing data and put it into good research that's valuable. That doesn't just tell us outcomes. Those are important, too, but how did we get there? What was the method? And what pitfalls did
And
we
money
find?
talks.
And money talks.
So if you are, I feel we're very fortunate at the university because a lot of the things that we do, administration is 100% behind us on it, but in real life, big hospital systems, if you're a cog in a big wheel, it's a big challenge to say, I've noticed when patients come in, they do this. I think it would work better. Kind of good luck. It's really a challenge. So when I've been in other positions, I would tell the patient, when you get your survey, please write down, because the consumers are listened to more than the employees, even if they know the right thing to do. So it's encouraging patients to feel empowered enough to speak up. And then once the research is showing these great outcomes, and we go to the payers, it's a much easier battle.
Now, I would like to answer just your second question, though, because, I'm with another health system. So I will say there are times, and I know, I myself, when I'm talking to some of the physicians that I'm working with, some of the primary care physicians, I'm on the phone with them and I'm thinking in my head, I would never refer anybody to this practice. I mean, I would just never do it because I don't like how you're treating my patient.
Yeah.
So honestly, as hard as it can be, if you're having a problem with your physician and you're going into an appointment, you need to address it. And it doesn't have to be rude. You can just simply say, I wasn't really comfortable with you next time, the last time. Now, if you don't want to do that and it's a bigger practice, when you call to make a follow-up appointment, you can say to the office staff, I met Dr. Smith last time, didn't really like him that much, can I switch to another doctor? And they'll do that. They'll never have to know if you don't want them to know. If you're still getting resistance, every practice has an office manager, and they interact with the physicians too. You need to go to that office manager. And I know it can't be easy because it doesn't want to appear that we're complaining, but they need to know because they want you there. But it's like you either have a conversation, one sentence. If you say one sentence to your provider and they come off a little rude, and I've seen it, I've heard it, then you know right there, I'm done. When I leave out of here, I'm done. And I'm either going to switch to someone else in this practice because you're not going to be the first one, or I'm going to go to another practice. Don't be scared to do it.
And in the larger health systems, they even have the patient advocate office that you can go to as
patient relations.
Patient relations that you can go to as
But I mean, I understand it because I hear it and I deal with it every day. And it's like sometimes you don't want to make an extra step. So you can change. You can absolutely change and say, all right, well, I'll have that new practice call for my records.
They won't change most of the time, or sometimes it's the patient needs to go to somebody else.
I think if you're feeling uncomfortable and you've tried to address it, then it is time to move.
But if you get enough of those surveys, then that healthcare provider will start losing business and realize that there's some disconnect, with either the bedside manner or something's happening. Because we even talked about it starts as somebody comes through the front door, so it's the hospitality and healthcare,
and
right?
some of that is what the other gentleman had said with social media. They have websites where people rate primary cares, and you can read some of them and kind of get a sense that, okay, well, that sounds like that was an isolated incident, but there's somewhere they've got 1 star and there's like 50. I wouldn't go to any of those people. So you really can shop around.
It's due diligence too.
Due diligence. That I think that is very important as consumers to actually do that due diligence on the upfront, and then even throughout. I think we have another comment or a question. And then we have 2 more over here.
Hi. I actually had an answer sort of to Tom's question over there. My name is Jen Reed. I am a consultant for Worldway Social Marketing, and we do some work on behalf of public health. So we're actually in the process right now of doing a sort of advocacy campaign towards oral health consumers based on the current opioid epidemic and trying to get patients to advocate for their own prescription choices and pain management. So it's going to actually be 2-pronged. We're doing a campaign towards patients to be more, to take an advocacy role in their own healthcare, but then also geared towards providers on not all pain is the same. There is other, options for pain management and working with your patient. So I actually have a question for you guys at the same time, which is, we talk about behavior change on the patient side, but what about for the providers? Rather than, just always looking for an alternative provider, what will it take for there to be some sort of behavior change on the provider side?
An open mind.
In big hospital systems, the surveys really do count towards that. I've been part of a very big hospital system. And unfortunately, a lot of times it comes from legislative decisions on the opioid crisis specifically. There's a lot of bad behavior that has occurred that has contributed to the epidemic. So, for people to go through and say, okay, I in good conscience don't feel that this is appropriate, you've come in, well, they can go somewhere else and get it. because there has been a lot of that happening. So at the legislative level, sometimes, and the state of Delaware did that this year, they put some pretty strict guidelines in for opioid prescribing. So people kind of need to fall in line, but it's unfortunate it took that. Because the writing's been on the wall for a long time, but it's happening. There's definitely some shifts within on a smaller scale. Practices and even bigger hospital systems need to adopt in-house policies for things, and then do peer review charts. When they get their evaluation through the end of the year, do some spot checking of the charts and call people out on the behavior. And it needs to happen.
It's transparency.
Yeah, it's
too.
transparency.
Like how do we show the transparency? Because markets are competitive, so they like to look at how they're measuring up against their peers.
And that's just one example, is the opioid. And that you make it money driven, where your bonus is, if you're lucky enough to get a bonus, and some practices get them and some don't, but your bonus is going to be held to patient satisfaction scores, which a lot of times it's Press Ganey. I don't know if you guys use Press Ganey. A score, and then also how many times did you prescribe antibiotics for bronchitis and things where it's not warranted. So sometimes the money talks there too.
Yeah, that's right.
Speaking of money talking, there's always some new competing priorities.
Oops. Was that it's my water.
Speaking of competing priorities like money, there's always some new public health priority that pops up.
Right.
And so, right now the opioid one is big up there, but we're looking at how do we campaign towards these providers with what we want them and need them to do when they're being hit with, well, maybe not oral health providers, but Zika or, the one key question, every woman, every time, birth spacing, like all of these different things that pop up. What can we do to get our message across to providers? Like we were looking at a PSA or some sort of provider toolkit and implementation plan, but there's a lot of those, and you're inundated. So
advertising in journals, coming to conferences and having a booth. Word of mouth counts for a lot. If you engage a few providers, people talk to their friends that are other providers.
And also the office managers, as Kelly brought up, every office has an office manager.
Reach out.
And sometimes they're the ones that can actually influence the behavior of that office.
That's a very good point. I was going to say the office manager does drive a lot of the office.
They're the gatekeeper.
You get in with the office, and they are, because the providers are so busy. The office managers, they see it, and they're the ones that are making those decisions. Really.
You can even try and do a luncheon, at the office. I mean, there's usually a break, and you can get in and kind of give your information. Give out some pamphlets, some handouts. It might not reach everybody, but it's going to reach some, and then there's going to be communication down the line.
Yeah, hi. You mentioned earlier the social support, which is very important for health outcome, and I want you to expand on that in the sense that 80% of the things that impact the health of a patient happen outside of the clinical walls. So how this model patient center, how do you integrate that community support? How do you work with the community, especially when we're talking about populations that are in need? So it is even more critical to have that support.
Rita and I talk about this a lot.
All the time.
So it's important for community outreach. And again, speaking from a UD perspective, we do a lot of health fairs. There's a lot of screenings that we do. And some of that's to advertise the services, but it really is, some people just don't know that their cholesterol is, 250. They have no idea. So you set something up, you have some entertainment, you have a few booths. Some of it's for fun, some of it's to get your finger stuck so you can check your cholesterol, and you leave with information that you didn't have when you came in. So we do some outreach there. It's from the community perspective, we try to engage patients with some of our specialty clinics, and some of these folks would never come to us otherwise, like the concussion clinic or the Parkinson clinic. But that's tough because the finances can be a barrier.
So part of that work is also what you see here on the STAR campus is how do we take the work that's going on here and take it out into communities that might not be able to access our campus. And also looking at, because I think you're bringing up also issues of social determinants of health and how that impacts. We know that people in poverty have poorer health outcomes than people who are not in poverty. So how do we also address those issues? In the university, I'm the director of the UD Partnership for Healthy Communities to actually advance within the community. But health systems now are also doing inventory relative to social determinants, because you would imagine those who are impacted by those challenges are also those who have the poorest health outcomes. So how do we better align it so those individuals are getting the support and the care they need to advance their health, as well as addressing those challenges that are impacting their health?
I also just want to add to that briefly that a lot of times as consumers, we are not even aware of all of these wonderful community programs until something urgent has happened to us or to someone we know. So we're not really being proactive, and we're not really being open and looking for these things ahead of time. I know that UPenn, I know Christiana, they're offering all of these wonderful community programs, and many of them are free. So regardless what your social status is, you can go to these things and learn more, but a lot of times we're not looking for them because that hasn't happened to us yet. So I think as consumers too, we need to be a little more open-minded and say, oh, this topic looks interesting, or let me just pop into Christiana's website and kind of see what's going on this month. Again, with that own accountability piece as well.
It's hard.
And I think this might be our last final question.
I had one question, kind of a comment. It sounds great about having the doctors work with the labs and everything. That's great when you're outside of a hospital. But once you get dumped into a hospital, you don't have any choices about what doctors you have, even though I already have a cardiologist. Well, this is who we're using. I already have. Well, this is who you've got. Whoever you've had outside of the hospital is totally different than who you have now. It's like two different worlds.
It is very true. That's very true.
You know, it's very frustrating.
The continuity of care piece is...
Are they required when you're inpatient, though, to communicate with your physicians that are on the outpatient side?
They are supposed to. It's rare. But ideally, unless you're out of state or, on vacation when you become ill, you may not get your primary care provider because almost no one admits their inpatients now. They have a hospitalist group that they're contracted with because they're there 24/7. But if you can't get your cardiologist, you should have one of his partners, because they're supposed to consult that group. So that should not be happening if you
It is happening, though.
So that's when you tell them you want to speak to patient relations and have them come to your room.
Oh, we have. And then you do get labeled as it, and
The heck with them.
Well, there's not too many different hospitals with certain specialties around, unless you want to go to like New York City.
So you're being the pioneer for the next people.
And patient relations, I mean, I've had family members with issues even at Christiana Care. It's a big, big system, and not everything's perfect. And they do pretty darn good, but there's a lot of opportunities for mistakes when it's that big of a system. And patient relations made a difference, and I felt like the response was genuine. I didn't feel like it was that my family member was being labeled. They said, "Oh, we didn't realize that was your cardiologist. It was a first-year resident. No offense, first-year residents. That they didn't realize that was your cardiology group. We can fix this." So keep speaking your mind.
The other thing is, you go in and they'll ask you for your list of medications. Mine is 2 pages long typed. All right, you give it to them, and you say, "I was in the hospital a week ago." And then they go and change them all. And you said, "Wait a minute, we just got this straight. I'm not here for that problem. You have a different problem." But they just, sometimes they just don't want to listen.
Yeah.
I agree.
No. Yes. I agree. Yes. But it sounds to me that you are a very good advocate for yourself.
Yeah.
And
I've got backup.
and you have the backup, which we said in the beginning.
That's really important.
It's always
Yeah.
good to have someone with you, you
Yeah.
know, to reinforce what you're saying, or many times to be the voice,
Yeah.
you know, of that patient.
Yeah.
And I think if more patients
Yeah.
actually do that,
Yeah.
that the system then will change. Systems, well, being a public servant for the 8 years that I was, I knew the system wouldn't change because of the public servants, even though they're trying to do the best they
Yeah.
can. Systems change because of the people that interface with that system.
Yeah.
And that's where, so even though you might not get the return right now, I do believe that the more patients that respond to systems of care as you do, that's what will influence and change for the better our systems of care. Any closing remarks from our wonderful panelists? Anything to take away? Final.
As a consumer, don't be afraid to speak.
Yep.
And as a provider, always listen.
Yes.
Yeah, that's good.
Yeah.
That's good.
Advocate for yourself
Advocate,
and your
yes.
family members.
And find people who will advocate with you as well. As these 4, you know, wonderful professionals, that's what they do. They're trying to influence the system from on the inside. And many times they can also give you recommendations as to what they see works. And even when we go into that more profound team-based level of care, I bet you they'll have one person on that team that every one of us will be able to relate to. And that's the beauty of that diversity of team-based care. We really appreciate you being with us this evening. I think the panelists would stay around to talk to you one-on-one. And please help yourself to the refreshments. Thank you very much.
Thank you.
Ooh, thanks for the questions.